Muy buenas tardes y bienvenidos a este webinar de la red Quest LAC, Evidencia de Calidad para la Transformación de los Sistemas de Salud en Latinoamérica y el Caribe. Ya son las 12 y en realidad quisiéramos comenzar a tiempo porque el día de hoy tenemos una presentación que va a plantear el inicio de los webinars que vamos a ir teniendo para desarrollar los conceptos que tienen que ver con calidad en salud. Primero quisiera hacer notar algunos aspectos técnicos. Esta presentación se está haciendo en inglés, pero tenemos traducción simultánea en español. Si quieren escuchar la presentación en cualquiera de los dos idiomas, lo que necesitan hacer es ver en su pantalla, en la base, al final, tienen el icono del mundo que dice interpretación, lo marcan y luego escogen ya sea el idioma inglés o el idioma español. Entonces, para aquellos que nos acompañan y hablan inglés, pueden hacer esto en este momento. So for everybody, we will have Spanish and English translation, okay? So you just need to check this little icon for interpretation and choose the language. La siguiente, por favor. Todos los martes, los últimos martes de cada mes, vamos a estar teniendo estas sesiones de más o menos una hora en la que vamos a tener expertos que van a estar discutiendo diversos temas que tienen que ver con calidad en salud. Los webinars van a ser vía Zoom, van a ser aproximadamente entre 20 y 30 minutos de presentación y vamos a tener la oportunidad también de hacer preguntas, para lo cual los invitamos a usar el icono de las preguntas, el Q&A, y también el icono del chat. Lo que sí les vamos a pedir es que se registren para los siguientes webinars en nuestra página web, que la tienen ustedes en la pantalla, www.redquestlac.org. Y para no tomar más tiempo, yo soy la doctora Patricia García y conjuntamente con el doctor Ezequiel, ambos estamos dirigiendo esta red y tenemos el gran gusto justamente de iniciar esta serie de webinars con la doctora Hannah Leslie. Hannah es investigadora científica de la Escuela de Salud Pública de Harvard, donde estuvo liderando el desarrollo de la encuesta Voz de la Gente para la red Quest. Ella realizó su maestría en salud pública y el doctorado en epidemiología. Su investigación de tesis se centró en los determinantes sociales del uso de sustancias y la transmisión de VIH e ITS. Completó una beca doctoral en la Escuela de Salud Pública de Harvard, donde se desempeñó como líder de investigación en la medición de la Comisión de Salud Global de Lancet sobre sistemas de salud de alta calidad en la era de los objetivos de desarrollo del milenio, y ahora trabaja como profesora asistente en la División de Ciencias de la Prevención de la Universidad de California, San Francisco. En esta oportunidad, Hannah va a hacer una introducción a los conceptos que tienen que ver con indicadores de calidad, y como van a ver, la presentación, ella va a hablar en inglés, vamos a tener la traducción al español y tenemos la presentación de los PPTs en ambos idiomas. Thank you very much, Hannah. Thank you for being with us, and you can start.
Buenos días y muchas gracias, Dr. Garcia, por la invitación. It's a real pleasure to be here today and present. I would note if you want to follow the slides in one language or another, you can exit full screen and zoom in on your Zoom screen on your preferred language. So, as Dr. Garcia said, I'm here today to provide an introduction to health system quality measures and survey data. I'm sure that many of you on the call have a lot of experience in designing or implementing or analyzing these survey measures as well. And so I hope to hear from you and your perspective as the seminar proceeds. So let's begin. The objectives of today's seminar are to introduce a framework for what health system quality means, provide an overview of where health system quality measures have been captured in existing data sources, and identify how these existing measures can be used to understand health service performance and population perspectives on the health system. I want to put this talk in the context of universal health coverage, given what a priority this has been for countries in Latin America and the Caribbean for several decades, and that the rest of the world is beginning to prioritize as well. So universal health coverage per the World Health Organization means that all people have access to the health services they need when and where they need them without financial hardship. So they're really emphasizing the dimensions of access and financial protection, not quality. But I think there has been a real realization that quality is at the heart of universal health coverage. And so you'll see that the advocacy group UHC 2030 defines universal health coverage to explicitly include quality. So UHC means making quality health services available for all, ensuring people are not pushed into poverty by healthcare costs. So why do we need to have quality along with the dimensions of access to health services and cost of health services? Well, an analysis based on some modeling for 2016 in low and middle income countries globally found that there were over 15 million deaths annually that could be prevented. And 7 million of these could be prevented through interventions beyond the health system. But 8.6 million were amenable to medical treatment and health care, and so were under the control of health systems. Of those 8.6 million deaths, over half, a full 5 million, were actually due to poor quality care. So these are individuals who did seek care for their health need, but did not receive enough care with sufficient quality to prevent their avoidable death. And in fact, we see that that quality is a key element of preventing excess mortality across conditions. So in cardiovascular disease, the majority of excess deaths are in individuals who are receiving care, but not receiving care with adequate quality. While there are a few conditions like cancer and mental health where the majority of the burden is still in individuals who are not getting care, so access to health services is really critical. You'll see in the English, the dark blue bars, in the Spanish, the light blue bars, the majority of excess deaths in many conditions is in individuals who are getting health services. So access is not the main problem. The main problem is the quality of care being received.
Hannah, I would like to ask you to go a little slow. That's what the translator is asking for. Thanks.
Okay. So before, if we turn our attention to Latin America and the Caribbean, before the pandemic, poor quality care was responsible for nearly 400,000 deaths every year based on this same analysis. And that's 70% of the preventable deaths in the region. And part of this is a good thing. It's because the efforts to ensure access to health services have been quite strong in this region. But it does mean that the major challenge right now is the quality of those health systems. You can see in the map, country by country, the estimates of what percent of those amenable deaths are due to poor quality care, ranging up to 85% in some countries. So really, by far the majority of deaths that are amenable to healthcare can be traced to deficits in quality and not a lack of access to services. And of course, this analysis that I'm presenting was from 2016. The COVID-19 pandemic of the past 2 years has revealed and exacerbated quality deficits. The direct and the indirect effects of the pandemic are worst where health systems are not responsive, integrated, and trusted. And I think we've all been living through that in the past 2 years. Okay, Patty, or still slower?
A little slower, maybe, so our translator will feel more comfortable.
Okay, I'll do my best. So as Patty mentioned, as Dr. Garcia mentioned, I was part of the Lancet Global Health Commission on high quality health systems. And in that commission, we defined a high quality health system. It was one of our first tasks. And I think it's important to note the emphasis on high quality health system, not just health care, because health services may be delivered according to different health needs, but they're delivered to the same individuals. And for a system to provide high quality care, the entire system needs to be high quality, not just visit by visit, but for the needs of every patient across their lifespan. So we defined a high quality health system as one that optimizes healthcare in a given context by consistently delivering care that improves or maintains health outcomes, being valued and trusted by all people, and responding to changing population needs. So again, thinking to the past 2 years, when we think of what health systems have needed to do in these past 2 years, they've needed to consistently deliver care to actually improve health outcomes. That's the fundamental purpose of a health system, is to ensure or maintain health. And then health systems need to be valued and trusted by all people, or people will not seek services when they need them. And we can see now in campaigns like the vaccination campaigns that trust in healthcare providers and in public health bodies is essential to population health, because we need to see trust in those systems in order for people to respond to the requests that are made of them in terms of the pandemic response. And health systems need to be nimble. They need to respond to changing population needs. In many settings, health services have evolved based on challenges like infectious disease, the HIV epidemic, and maternal and child health, and are now faced in the past several decades with the increasing burden of non-communicable disease. So that's one way that health systems have needed to pivot to long-term sustained care for disease management. And then again, in the last 2 years, we've seen how health systems need to respond to the direct and immediate challenges of the COVID-19 pandemic while attempting to continue to deliver the essential care that they were providing before the pandemic. Now, I want to say that there is not just one definition of quality or one framework. And I don't think that there needs to be a single framework to encompass health system quality or healthcare quality. I think what is important is that any research or policy related to quality define in advance how it's approaching quality measurement. So one of the sort of seminal frameworks for health care quality in the US, which strongly influenced the Commission and has influenced many other quality definitions globally, is the Donabedian Quality Framework. And this was helpful in terms of operationalizing where you can look to define health service quality. So what Avedis Donabedian, a physician in the US, defined was the structure, so structural quality, the physical and organizational characteristics where healthcare occurs, which is a precondition for process quality. So here you're focusing on that care actually delivered to patients, services or treatments. And high quality structure and high quality processes should yield outcomes in terms of the effect of healthcare on the status of patients and populations. And we can think about each of these pieces when we decide how to measure healthcare quality. And when we put together the framework for the High Quality Health System Commission, we took these same ideas from Donabedian. You can see the foundations at the bottom are a broader view of his structural measures of quality. And then the processes of care, really the heart of the clinical interaction between healthcare providers and patients. And then the quality impacts, which includes better health outcomes. So our effort here was to take those same ideas, but put it in the broader context of the health system to understand that we need to consider all of the foundations for a high quality system, from the population, the governance and policies, the platforms, so primary care, secondary care, referral care, the workforce, obviously the heart of any health system are the healthcare providers, and the tools that they need to provide good care, whether that's medications, diagnostics, data, health information systems. The processes of care can be defined to include both care competence, so within a visit, whether a provider adhered to the expected guidelines for providing competent care, between visits, whether you have continuity of care or you have integration of care, like a good referral system when necessary, And that positive user experience, which has also been defined as patient experience or the respect and health system responsiveness. And again, if those pieces are delivered with high quality, then the impacts should include better health for the population, confidence in the system, or we might say trust in the health system, and economic benefit in terms of both financial protection and a return to work or a return to education, so you don't see that loss of productivity due to poor health. To make this a little bit more practical, so I gave an example here. So in the population domain, we might consider that individuals preparing to give birth would expect to have a companion with them during labor and delivery. The platforms, the health facilities, would need to have adequate space for each individual to have a companion present. During the actual labor and delivery, to have a positive user experience, the healthcare providers would need to ask about whether there is a preference for a labor companion, ensure that that person can be present at all times and engaged in decision-making around delivery. And these processes might yield an increased confidence in the system, such that both the individual delivering and the companion are satisfied with the care received. And there may be effects on health outcomes. Studies have found that having a labor companion can increase the chance of the child being delivered vaginally with no complications, so helping to avoid unnecessary C-section. So this would be one way you could operationalize the framework for a specific care service, in this case, delivery. Taking a second example, if we look at non-communicable disease, one of the requirements of the workforce would be that there would be healthcare providers with training on the management of diabetes who would be available where individuals are seeking care. The tools that would be required would include appropriate diagnostics and medications to be in stock at those facilities. Care competence would be that the healthcare providers are able to recognize complications of uncontrolled diabetes, as an example, and refer the patient to a hospital or to the referral facility that's able to provide that level of care. The system competence would be demonstrated if the hospital is able to receive the referral with the full patient history and information in a timely manner and provide the appropriate treatment. And then this could be realized in terms of economic benefit if the length of stay is brief and the patient is able to return to work shortly. So from the prior slides, you can see, if you weren't already aware, that there's a huge number of ways that we can measure quality. There's different clinical services, there's different domains of quality, there are different ways that we can operationalize a given indicator. So I think a part that has been missing from many efforts around quality measurement is defining in advance what measures actually matter and what is important to measure. Because that should really determine everything else: what you're measuring, where you're measuring it, how often you're measuring it, how you're using that information. So the High Quality Health System Commission suggested that there are two main purposes, and that measurement should meet these purposes or it shouldn't be done, because measurement obviously is not free. It takes time and money to measure. So we should only do it if it's going to meet one of these purposes. One is accountability. So here we're talking about using data to enhance transparency and including benchmarking progress relative to agreed upon standards and targets, for which we would need indicators that can be readily understood as related to healthcare quality and that can be compared between regions or across subpopulations or over time. Then for action, here we're talking about using data to diagnose problems, to really guide the scope of health system improvement interventions and to assess intervention effects. And this may be quite a different type of information depending on the scope of the improvement. So if you're trying to do quality improvement in a specific set of facilities, you may need very rich information about where the problems are occurring, what the issues are, whether in communication or leadership or supply management, and then how you can best change those. So I know that future webinars will focus on quality improvement efforts, and I think we'll have opportunities to learn further about the types of information most useful for improvement. But I think a real priority in the field is to distinguish whether the data being collected and used is for accountability or for action. I think there's often confusion that we may be able to measure something and hold the health system accountable, but it doesn't necessarily guide direct action. So thinking then of the different elements of our high quality health system framework and what we can learn from each of them in terms of accountability and action, we can start at the bottom with the foundations. So timely and specific information on the inputs to care is really crucial for health service planning and operation. It's important to know if there's been a stock out of medication, if equipment is damaged and needs repair, if there's a workforce shortage that is compromising the delivery of services. But that information needs to be really a fuel for action. So it should be measured cheaply and frequently, so that the response can be directed to repair that gap as soon as possible. The measurement of foundations like medications, diagnostics, equipment alone isn't going to tell us about the quality of care provided. So I think it's not a very useful set of measures for accountability, and not necessarily useful measures if they're done infrequently, because just knowing that the right stuff is in place is insufficient to tell us whether care is delivered according to standards and whether that care improves health outcomes. So then if we look at the processes of care, these are very immediate and relevant to the point of care. They're telling us whether the right things happened in a provider visit, whether a patient was treated with the respect that they deserve. And these measures can be applied across all types of patients because we don't need to adjust for how vulnerable a patient might be before the visit. We know that they should receive care up to a given standard regardless of their prior vulnerability or risk. But it is important for process of care measures to be very judicious in their selection because it's quite time consuming to collect these, particularly if you're asking healthcare providers to report on things or to fill out to fill out indicator reports or to provide information on the care they provided. And so it's very easy, I think, to ask for additional information on processes, but doesn't necessarily come with the right use of that information to inform future care. So I think process of care measures are certainly essential, but they really need to be picked very carefully so that they're not putting additional burden on the healthcare system. Then the final piece in terms of quality impacts are essential in that they attest to the central goal of health systems, which is better health. If a health system is not helping to improve or maintain health, then it's failing at its central goal. But we do have to be quite careful because it can be difficult to attribute health outcomes to the health system. There are many conditions where people will recover even if care is not high quality. And there are conditions where where the disease may get worse, even if care is high quality. So that is a challenge, particularly for some of the less common outcomes. So we want to focus on outcomes that are really sensitive to the health system, where the actions of the health system should have an effect on the health outcome. And then to think about patient-reported outcomes, which again may be more sensitive to health system actions. So I've already sort of laid out that there's quite a few possible measures. There's also a range of sources of quality measures, which includes administrative data, electronic health records, population surveys, facility assessments, which may include an exit survey, patient registries, and vital and civic registries. And I'll pause here to note this also is from the Commission, which is available in English and Spanish at hqsscommission.org. So I can make sure that's link is somewhere in here. So just to say, I know I'm covering a lot. It's a lot of it up until this point is in the commission report if you're interested in more details. So we have this range of sources of quality measurement, which can tell us, provide us with different angles on how we want to understand health system quality. And the part that I'm going to focus on today is survey data on health system quality. So thinking about population surveys and then surveys of users of the health system. And these data are primarily useful for accountability and benchmarking because it's a survey, it's cross-sectional and periodic, so it's not going to be useful for informing specific action for quality improvement. They're most relevant for commonly used services because again, it's typically sampling a cross-section of the population. So it's going to be based, you'll get more information on health needs that are more common in the population than on rare outcomes. And one thing that I've observed in my work and research is that the use of these data can be hampered by poor integration with health system policy, with a lack of guidance around what the most important indicators are or the composite measures. And often the groups doing the surveys may not be the same as the health system policymakers in a region or country. So I think that's been a challenge for the use of survey data on health system quality. So the types of measures that we can get from surveys depend a bit on whether it's a population-based survey or a user-based survey. So I'm going to start by going through population-based surveys. These can be face-to-face, like with a household-based sample, or they can be administered by phone or internet. There are some that are nationally representative or subnationally representative, or that are applied over multiple countries to be standardized across a few countries. There are many that are country specific, that are developed and administered in one country or one region of a country, and others, again, that are standardized and used more broadly. If the survey is taking place in person, there may be some additional information like blood pressure or anemia in some cases. So the types of things that we can find out from population-based surveys are around the need for services and the use of services. These are not direct measures of quality, but they're important for understanding population needs and current use and non-use patterns. Then specific quality measures, there may be self-reported process measures. So the content of care during your recent visit or the positive user experience during a recent visit may be asked. In the quality impacts area, we can understand the non-use of care related to lack of confidence in health system in some surveys. And then there may be economic items, so financial protection or catastrophic health expenditure. I'll give a few examples of these surveys in the Latin American and Caribbean region. So one that's cross-national was the Primary Healthcare Access, Experience, and Coordination in Latin America and the Caribbean survey, which was conducted 2012 to 2014 by phone in 6 countries. The data are publicly available from the Inter-American Development Bank, which sponsored the survey. They have because this was a healthcare specific survey, it has a ton of interesting information on healthcare use and quality perceptions. Some of the major measures that were used in this survey include user experience. So how easy or difficult is it to communicate with your regular healthcare provider? How often does your provider explain things in a way that is easy to understand? There's questions on system competence, one of which is how long did you wait for non-emergency surgery? So how timely is the health system in responding to specific health needs? Among those who recently needed surgery, which will obviously be a much smaller sample than the full survey. There were several questions on confidence in the health system. So stated confidence, how well do you think the health system is currently working? And then what's called revealed confidence, which is a non-use of care. So was there a time in the past 12 months when you needed health services and chose not to seek them, and why not? And then financial protection. Were there times you had serious problems paying or were unable to pay your medical bills? So an example of the use of this information is in this survey led by Ricardo Perez Cuevas, which looked at the question of whether respondents believed the health system needed fundamental change or complete rebuilding. And they were able to summarize this information across all 6 of the countries in the survey. And you can see the results as they reported them here. And so this sort of information can be useful in calling attention to deficits in health system quality because it enables a policymaker to compare, for example, if you are in Mexico and note that nearly 20% of respondents, if you're in Mexico, that 80% of respondents believed that the health system needs fundamental change or complete rebuilding. And in Brazil, this is actually approaching 100%. So this indicates a very strong support for major policy change to the health system and a very high level of dissatisfaction with the current organization of the health system. It doesn't tell us what sort of changes are required or how to start. So this is why it's useful for accountability. It could be measured again now and see if things have been improved since then. So again, useful for comparison between countries and over time, and to help provide the motivation for change. Does not necessarily say what that change should be. Now, a standardized survey that has been administered across multiple countries, but is designed to be used country by country. To give an example of that, I'll use the DHS, or the Demographic and Health Surveys, originally developed in the US at USAID. They've been used worldwide. This map shows how many have been done in the Latin American and Caribbean region. And some of these, I know that countries have taken on the survey tool and adapted it and made it more useful for their own purposes. And so those are not necessarily listed on the map, but they are also can be available from the National Statistics Agency in a given setting. So the DHS surveys are nationally representative household surveys. They've traditionally focused on maternal and child health and nutrition. So those are the services where they provide the most information. They include a few relevant questions. They have a ton of questions overall, but only a few are actually relevant to quality. So for example, they capture competent care during pregnancy through self-report. And all of those that have been done in coordination with the DHS program are publicly available for anyone to use. And so the way that these surveys have been used is to help provide accountability between countries, but also across population subgroups, because they do collect information on individual sources of vulnerability, like poverty or low education or ethnicity. They can be used to compare the health system performance across these population subgroups. Here's an example from a recent article in the International Journal of Equity and Health from Cesar Victoria's group, where they created a score that combined the use of antenatal care with the quality, the content of that care. So combining the use and quality measures. And then here they show the content adjusted coverage of antenatal care for the countries that have had a recent DHS by wealth quintile, from the poorest to the wealthiest in each country. And so the span of those dots shows the size of the inequity in that country. So countries at the bottom, like Mexico and the Dominican Republic, are showing the least inequity in the content adjusted coverage of antenatal care, and the countries at the top, like Haiti, show the broadest inequity and the biggest gaps between the care received by the poorest individuals and the wealthiest individuals. So again, this information can hopefully spur greater attention to these inequities and help to identify the populations who are receiving the poorest content adjusted coverage. Then to turn to national health surveys, which I think are probably the most diverse bunch of surveys of the ones I'm presenting. I think they've been done in many, many countries, and I'm only presenting just a few examples. So one example is the NSANUT, or the National Survey of Health and Nutrition, which has been done in Mexico several times, as well as Ecuador. There's a National Health Survey in Brazil that was done twice in the last decade, and again, a range of others. So these are typically nationally representative household surveys that will include measures of health service utilization and health status. And then among those who have used health services recently, they may ask things like user experience, confident care, and confidence in care, often looking at satisfaction with care received. And some of these, as I mentioned, if they are done in person, can also include biomarkers. So this is an example of using information on whether care was sought, as well as current health status, in this case, blood pressure, to calculate what's called effective coverage. So if the health system is providing effective care for hypertension, that means that it is identifying individuals with elevated blood pressure and providing those individuals with adequate management or treatment strategies to bring their blood pressure under control. So this is one of the few conditions where we can use a survey to understand whether an individual knows that they have hypertension, and then with the blood pressure measurement, whether their blood pressure is currently under control, representing disease control, and whether they've been using services for that hypertension. So you can see here in the plot is a comparison across states in Mexico from an article led by Dr. Lozano quite a while ago now, one of the really seminal articles in effective coverage, where you're able to see in the lighter green the proportion of individuals with hypertension who are using any services for it. So that's the access to care or crude coverage. And then in the darker green, the percent of individuals who know they have hypertension but are currently on treatment and have disease control. So that's where you really see whether the health system is providing effective care. And again, the gaps that we see here between states can be a spur for policy to help address the low levels of effective coverage that we see. So to sum up these population-based surveys, they provide representative samples of the full population. So it means typically a large number of people. We can get perspectives from both users and non-users of health services. Sometimes they can include basic biomarkers if it's face-to-face and if there's the funding available for that type of data collection. The downsides are that it can be a small number of people for those who need or use a specific service, and the time frame in which they've used that service will vary between people. So for maternal health, they often ask about pregnancies in the last 5 years or antenatal care received in the last 2 years. And then from our perspective in terms of the health system, respondents are not linked to specific facilities or services. Sometimes we'll know they'll be asked if they went to a Ministry of Health facility versus a private facility, but we don't know the specific place that they went. So their responses are not going to be able to inform action in terms of specific facilities or subsets of facilities. Then these surveys, again, they're cross-sectional. The recall will be over differing timeframes, and it's a self-reported measure. So there's evidence that recall of whether specific medical care happened is going to differ person by person and by the type of service. So now let's turn to user-based surveys, which I think are less common than population-based in global perspective, although I think they have been done fairly commonly in Latin American and Caribbean countries. So these can be at the health facility as an exit interview or after a visit, like a phone, email, or text, SMS follow-up. They can be service specific, so just people who came for a particular type of care, or platform specific, everyone who came for primary care, or cross-cutting, everyone who is leaving a health facility regardless of what health need they came for. And again, there's tools that are developed in specific settings and tools that are more cross-cutting or standardized. They commonly capture the same 3 domains that we saw commonly captured on population surveys in terms of user experience, content of care, and satisfaction or confidence in the system. A cross-national example of these is the service provision assessments, which are done by the DHS program. And there's some other ones developed by the WHO and the World Bank, which haven't had as many interviews of patients so far, but those tools are now being updated to include exit interviews with individuals. But these have been used more commonly in other regions of the world than in Latin America and the Caribbean. So there was a service provision assessment conducted in Haiti in 2013 and again in 2017 and 2018, which included exit interviews for people using antenatal care, sick child care, or family planning. So they asked those individuals about the content of care in the visit, their experience of care, and their satisfaction. And again, these data are publicly available. And then there are country-specific exit surveys where there's a sample of health facilities and exit interviews are conducted with the clients, for example, of outpatient services. So an example is the En Su Salud in Peru, which was conducted annually from 2014 to 2016 and is available at these links, or the NSAT in Mexico. And so these also measure user experience and then the confidence in care or satisfaction, whether you recommend the facility. One benefit of these surveys relative to the SPA that I was just talking about, the service provision assessment, is that they also include some more detailed individual information to help us look at equity and inequities in the delivery of care. So one way that these can be used is kind of summarizing the information at the individual level. This is from a study published a few years ago led by Dr. Kelsey Holt using the NSAT survey in Mexico. So looking at patient experience among users of primary care facilities, where the major measures were verbal and nonverbal communication. I know it's a bit hard to read, but what we could do with this type of information is say, among these measures of communication, the one that was least likely to be reported was eye contact with the patient on arrival. So that could be considered as to if that's a priority, since it is asked on the survey, then that might be an area to consider for additional training or notifications to the health services. So we can use these to see among the measures asked, which are showing some deficits in health system performance. And then we can also consider using this information at the facility level. So this is from a recent project that I worked on with Dr. Garcia, where we looked at the satisfaction that people reported when they were leaving the health facilities in Peru, and also whether they would recommend that facility to friends or family members. And one of the real challenges with satisfaction is it's not solely a rating of what happened in the visit that day. Research shows that individuals come in with certain expectations of care, and they also come in with an understanding of what they think may or may not be feasible in their health system that they are used to. And satisfaction measures are strongly influenced by that, so that people may come in with expectations that they will wait for a long time for healthcare because they have always done that, or because they know the health system is overwhelmed and they don't really expect to be able to be seen quickly. So we found that satisfaction in many surveys can be quite high and make it hard to distinguish better or worse facilities. So here in the red, what we did is we summarized satisfaction to each facility level. So each dot is one facility, and you can see there's a fairly flat line. So over 2/3 of facilities were indistinguishable from average. So you can't really tell if they're actually better or worse than each other based on the satisfaction response. In the blue, we used the item from the same survey, which asked people if they would recommend the facility to friends or family. And we saw that that question actually did help separate facilities a little bit better, so that many more of the facilities could be identified as below average and perhaps targeted for subsequent improvement. So wrapping up, user-based surveys are designed to capture users of the health system based on the health need or where they've gone or the services that they've sought. So the big benefit of that is that it's linked to a specific source of care. So we may be able to summarize the responses to provide some insight on some of the quality strengths and deficits of a particular facility or a particular region. And we typically get more detailed quality measures than population surveys because they're specifically intended to capture what happened during the care visit. So you'll see they may have multiple items on user experience or content of care. But again, they're still cross-sectional, so we're not really getting information on what happened after the visit in terms of health outcomes. We're not getting information on continuity of care, any of those measures of system competence. As I mentioned, with satisfaction, the responses may be really influenced by what people expect from the care that they're seeking. And so that can make it difficult to use the information to identify better or worse performing facilities. And then the amount of information we have about the individual patients can vary. Sometimes there's just a few questions. Sometimes you have enough to disaggregate to look at patients who have different health needs, or patients who are coming in with different levels of education, for example, and can better advocate for themselves. So overall, I would say that population surveys and periodic health service user surveys provide information for assessing quality of care, particularly for accountability, so benchmarking and comparison, particularly related to patient-reported experience, and the examples that I've shown at sort of the national or subnational level. Many of them are publicly available for secondary analysis, and just to reiterate that probably the single most common measure used is satisfaction with care, but that can provide limited insight given that many people simply respond that they're satisfied or they're very satisfied. Some things that I think are underway or coming in the future are to use more inexpensive modes of measurement, so phone or text, which would help to reduce the cost, obviously, and potentially make it easier to do surveys more often, so that we can actually monitor changes over time and use the information in evaluating health system interventions. I think there's an increasing focus on patient-reported experience measures, and if those are asked in a standardized way, then we can compare more broadly across surveys. One challenge, I think, is integrating survey information with other modes of assessment, like patient registries, which will tell you more about care over time, so that policymakers will be able to use both the broad cross-sectional survey data and the deeper, longer-term, but more narrowly focused patient registry information. One thing that I think would be helpful is to have more predefined survey objectives to better incorporate the findings into subsequent research and policy. I think quality measures are often included in surveys without necessarily having a plan for how they should be summarized or how they should be used. So we're left with a lot of data, but not a whole lot of information. And that's it. So thank you very much. And I look forward to questions. I see there's already some in the Q&A.
Muchísimas gracias, Hannah. Thank you so much, Hannah. It has been so interesting, and muchas gracias a todos los participantes que están interactuando. Tenemos gente que viene, bueno, obviamente Perú, Venezuela, Ecuador, Colombia, México, Panamá, Paraguay. He visto muchos que también han estado dando saludos a través del chat. Tenemos, ¿no se me está escuchando?
Yo sí.
Por ahí, no sé, Silvia Isabel Neira dice que no se escucha, pero me dicen que sí se escucha, por otro lado. Ahora tenemos 10 minutos para preguntas. Tenemos varias preguntas en la lista y voy a tratar de juntar algunas de ellas, ¿ok? Entonces, Hannah, tú has hecho una exposición muy buena en la que nos has hablado inclusive de cuáles son los niveles, diferentes niveles y diferentes formas en las cuales se puede medir la calidad, pero también cómo medir la calidad, o sea, niveles, me refiero dentro del sistema de salud, pero también diferentes formas, porque podrías medir estructuras, procesos, impactos. Varias de las preguntas tienen que ver con el hecho del problema de los costos, ¿okay? Porque, por ejemplo, nos dicen que usualmente las mediciones de calidad son infrecuentes porque hay reducciones presupuestales y entonces, ¿cómo conseguir mejoras? Por otro lado, otros nos dicen cómo hacer entender a los profesionales, a las autoridades, que medir la calidad no necesariamente es costosa. Y a eso quisiera adicionar que ponen muchos de nuestros países en la región, estamos divididos por gobiernos federales, ¿no es cierto? Divididos. Y si tal vez pensando en la gobernanza, y cada uno tiene su propia oficina de calidad, tener una cuestión más alta podría permitir trabajar mejor calidad. Entonces, el tema de los costos de las mediciones y finalmente, también juntando, perdónenme, pero estoy juntando varias preguntas, ¿cuáles podrían ser los mejores indicadores de calidad que pudieran ser, si tenemos alguna evidencia de indicadores costo efectivos de calidad para poder sopesar este problema de la falta de recursos y no entender que hay que hacer mediciones de calidad? Después te hago la otra pregunta.
Yeah, so I think that's a great question. And I think it goes back to the idea that we should know what we're using the information for before we collect it. Because I think part of the reason, obviously surveys can be expensive to do, but they are particularly expensive if they're not useful, because then the people who paid for them don't know why they paid for them. So I think the emphasizing the need to use measures like these for accountability and hopefully having that information collected by some of the same groups who might act on it is one piece. A second, which I'm very excited for the Quest LAC to work on, is providing more insight into what the minimum set of measures might be and what some of the least expensive ways to capture those measures might be, so that the measurement itself can be less expensive and more useful at the same time. I think some of that relates to, so I think a small set of measures on care competence that could be asked at facilities or by text. So for example, if you have brought a child to a health facility for a sick child visit, when you leave, do you know their diagnosis? Are you confident in what your next steps are as a caretaker? Do you know a danger sign where you need to bring your child back? So very short, that gets at what the essential information you should have when you leave the visit is. Then I think for patient experience, we can think of 3 or 4 questions. The OECD has a set of 4 measures that are mainly about communication and respect. I think they can be, there are examples from Latin America that are similar, to have a short set that really just focuses on whether you were treated with respect, that would apply across settings. And then I think the one of the tricky issues that I hope, and I know Quest Latin America will be working on, is these measures of confidence in care. So satisfaction is easy to ask, but hard to use. We need ways to understand people's expectations of care in hopefully short items, or short set of items. And we need measures maybe like recommendation, maybe like your confidence in the system as a whole, that might move people a little bit away from their reluctance to criticize their own doctor or their own clinic and help them to speak to the performance of the system as a whole. So I could envision this is somewhat similar to the People's Voice survey that the Quest Latin America will be working on, but a phone or internet-based survey that has just a few questions on confidence in care and non-use of care, because non-use is telling us that someone didn't feel like it was worth going to get health services, whether they would be treated poorly or they didn't think it would help them or it was too expensive. And so those are the indicators that I would prioritize. So yeah, I think it's two-pronged. It's trying to more closely integrate research and policy so that the information that's collected is actually used, because I think there's a reinforcing cycle. The more information is used, the more people recognize how useful it is. And then I think those are my priorities in terms of the domains for survey measures. There's certainly other measures, as I mentioned early on, from within the health system that we need to speak to care competence and system competence and health outcomes, but those aren't going to come from surveys, in my view.
Muchas gracias, Hannah. En realidad, muchas de las preguntas se localizan en esos dos grandes temas. ¿Cuáles serían las mejores variables? ¿Cómo hacerlas más costo efectivas? ¿Cómo podemos hacer que no solamente se hagan encuestas, como dices tú, se recojan datos, sino que al final sea información que nos permita no solamente rendir cuentas, pero también hacer cambios y acciones? Hannah nos ha presentado en realidad una mirada general. Esto es el comienzo de la discusión. Justamente la red Quest en Latinoamérica, en la red Quest Latinoamérica, lo que estamos tratando primero es de identificar qué hay, qué se ha hecho y por qué lo que se ha hecho no está llegando al cambio. Y una de las cosas que también mencionó, uno de los objetivos, es tratar de evaluar, había un comentario de un epidemiólogo, validar cuáles podrían ser esas mejores mediciones, de tal manera que no tendríamos que hacer costosísimas encuestas, ver cómo podríamos medir mejor, ya no la satisfacción, tal vez la experiencia, la competencia del sistema, la confianza que tiene el individuo, ver cómo podemos medir estos aspectos, validarlos contra la realidad. Eso es parte de las tareas que queremos hacer con Quest Latinoamérica, y qué bueno que eso haya sido parte de la discusión el día de hoy. Desafortunadamente ya casi estamos por terminar. Hay una pregunta más que quería, Hannah, muy cortito, que tenía que ver con el sector privado versus el sector público, ¿ok? Vemos que hay más avances en el sector privado con respecto a cómo medir la calidad. ¿Qué cosas podríamos aprender de ellos?
That's fascinating. Yeah. You know, I think that the private sector treats health services more as a consumer good because they know that individuals can choose or not choose to use that source of care. And so they, I think, in many contexts have approached it more from that idea of what value can we provide for the cost that we're charging. And I think have, in many contexts, I'm speaking quite broadly, worry about overgeneralizing, but work to optimize things like patient experience so that people feel that they have been treated well and that they feel their money has been worthwhile. Whereas I think the public services have often approached it more as, we're here, you can come use us if you want to, you know, what you get is what you get. And often many people using public services will have different expectations than those who have the financial capacity to opt out of the public system. So I'd say, I think one key piece is having this, which is not, I think, for surveys necessarily, is more of health information systems, to be able to compare patient outcomes across private and public, because I think there are probably private practices that are able to optimize patient experience without necessarily optimizing the quality of care. And I think there are some that are able to do both. So that, I think, is one key piece that it's important to be able to hold any practice, any clinic accountable for the outcomes that should be under its control. And then what we can broadly learn, I do think that the orientation towards value and what value the patient receives, whether that's in terms of their functional status, whether it's in terms of their kind of respect or their respect for their time, that the waiting time is not excessive. So I think that that is a real challenge to figure out how health services can continue to be public goods, but recognizing that individuals do make choices, and some have more constrained choices than others, but health systems should meet the needs of everyone coming to them. So I think a really fascinating area. Sorry, just to scratch the surface.
Muchísimas gracias, Hannah. Y quisiera terminar con un comentario que nos hacen en las preguntas y respuestas, ¿no? Dice, las expectativas sobre la atención en salud de la gente, o sea, del paciente o el usuario, están estrechamente vinculadas a su percepción, o sea, y a lo que saben, y a veces limitada por lo que saben que van a tener ahí también, y su cosmovisión de la salud. Sin embargo, lo que también es importante, y eso lo ven también en el sector privado, es el valor por el costo. Yo creo que, tal como lo ha dicho Hannah, tenemos que cambiar la visión, porque lo que necesitamos, la salud es un derecho de todos y debería darse con calidad para tener mejores resultados, para realmente tener el impacto. Esto solamente comienza la discusión. Muchas gracias a todos los que nos han acompañado. Tenemos todavía 179 personas de diferentes países con nosotros. Estamos tomando en cuenta todas las preguntas que se han hecho y los comentarios, porque probablemente en nuestra página web vamos a abrir un espacio en el que tengamos preguntas y respuestas, discusiones, porque eso es parte de lo que queremos hacer con el Quest Lab. Les aviso que en la página web vamos a tener la grabación de esta discusión y de este webinar que va a estar accesible a todos. El próximo mes, el cuarto martes del mes de febrero, vamos a tener el siguiente webinar por el doctor Ezequiel García Elorrio, que va a ser acerca de los hallazgos de la revisión sistemática de mejoras a gran escala. Entonces, el otro lado, no solamente medir, sino cómo podemos hacer algunos cambios. Y así vamos a seguir discutiendo y también los invitamos a hacer sugerencias sobre los temas que quisieran que se discutieran en este webinar. Quiero agradecer a todo el equipo que nos ha acompañado, a Hannah por su presentación, a Eugenia, a Agustina, a Laura, a Verónica, que ha sido nuestra intérprete. Muchísimas gracias. Y también al equipo de técnico que nos ha ayudado. Muchísimas gracias y con esto terminamos el webinar de hoy. Muy buenas tardes.
Buenas tardes.